All right, thank you very much. So can you repeat that question again, please, Carlos?
Sure. So the question is basically, just give us a brief introduction of your philosophy and care model. I think we're really interested in looking at care models and how do you integrate, infectious disease and opioid use disorder under one roof, on sort of a patient-centered approach.
Right. So I think that the most important, I think the way that I would characterize it is it's a family medicine model of care. So it's rooted in the family medicine model, and it integrates prevention, care, and treatment across all domains as a result. Family physicians, I think, are trained in not just treating specific diseases, but in prevention. And so I think this has been kind of a natural fit for us. So hopefully that answers your question.
I think that's actually incredibly useful. Let me just start with asking sort of the first question. Tell us a little bit about how you do, sort of harm reduction. How do you have a harm reduction culture and philosophy within your organization? And how is there resistance from individuals or from even the community about having a harm reduction approach?
That's a great question, and I will say that it's been a journey. We've been providing buprenorphine treatment in our clinic for several years, probably over a decade, but we haven't always operated on the harm reduction model. We've really only recently kind of embraced that model more fully, particularly when we began providing care for opioid use disorder on our mobile health unit, so where we're really focused on the homeless population. I think that was kind of the point in time where we saw a clear move from our previous model, which I wouldn't call punitive necessarily, but kind of, trying to it wasn't necessarily harm reductionist. And so I think the real shift, the real paradigm shift came when we transitioned to providing more care in the community, particularly on our homeless van. There has been a lot of resistance, both within and without. I think it's really hard for our staff when they see me prescribing buprenorphine for a patient, and then that same patient the next day coming in and getting more needles through our SSP program. I think that they struggle with that. I think that even we as providers often struggle. We wonder how much good are we doing when we continue to see our patients really struggle. Fentanyl has been a huge problem in Lawrence. And it's a different beast in terms of how it affects the brain. At least it appears to be. We've noticed that patients who are injecting fentanyl are doing so on average 5 to 10 times a day, sometimes even more. So that's a number of injecting events every day. Quite honestly, buprenorphine hasn't always been sufficient in order to keep people from feeling sick when they come off their fentanyl. So people continue to use as a result, and that has been a real challenge. There's also been a lot of resistance within the community. There was one gentleman in particular after we started our SSP program who would go around and take pictures and video of discarded needles in public places and post it to Facebook in an effort to really drum up opposition to the SSP program. And so that's been something that we've had to deal with. We got a grant to get to have syringe disposal bins placed strategically in public places, but then after we got the grant, unfortunately, the city decided that they did not want those disposal units in public places, so we had to put them on our own clinic property. So it kind of did not achieve the purpose for which it was intended.
Thank you. That was very useful. I'm going to ask the committee members to put up their tent, and that way we go ahead and ask questions. And Ellen, you're number one. Oh, you want to go? You have a presentation?
I'm sure I'll hit on all the major points as you're asking.
I think we're
Please,
better. I think
no,
I'm much better
'cause
have a
it's-
dialogue.
Yeah, I think I'm totally fine doing a dialogue.
And if there's a slide you need to pull up to answer a question, feel free to do that.
Okay.
And just say,
That sounds
let
good.
me show you a slide or whatever.
Yeah, that sounds good.
I'm Ellen Eaton from UAB. Thanks for coming. So I noticed in your bio a comment about inpatient HIV and addiction medicine services, and one of the things we've discussed are some of the newer acute bacterial infections, which may not have an infectious diseases home in the community like HIV or Hep C. And I'm just curious if there are processes to link those individuals who may be HIV or Hep C negative to community-based addiction and or infectious diseases care, and if that is at all integrated.
So we are working on making it more integrated, and the process by which we're doing so is through our addiction medicine consult service. In order to kind of understand, let me just kind of can you go to slide, sorry, I can't see what slide this is. The one that starts Greater Lawrence from here. Next slide, thanks. So we have a family medicine residency. And one of the unique things about our family medicine residency is that it's a 4-year training program. We're one of a dozen or so family medicine training programs throughout the country that has a 4-year model. As part of that 4-year training model, all of our residents are required to choose an area of concentration. They can choose from a number of different areas of concentration, including HIV viral hep and addiction. A few years ago, when we started the HIV program, the HIV AOC, we thought that it would be really beneficial educationally if our HIV AOC residents could go into the hospital whenever one of our HIV clinic patients was admitted and support the team in caring for those patients. Usually by doing med reviews and making sure that people were getting the appropriate ART care, and then also, if patients were admitted for OIs. Doing an evaluation and assessment for what was going on there. They were still, for patients admitted with OIs, they were still getting an ID consult, a formal ID consult, but it was kind of meant as an educational experience. We have now, with our addiction medicine AOC, we've modeled a similar inpatient consult service. So anytime anybody with substance use disorder is admitted to the hospital for any reason, and when I say anybody, I mean a Greater Lawrence Family Health Center patient primarily, the addiction medicine consult service is activated. And so they are going in and they are focusing on the treatment of the addiction component of their care, but while they're in the hospital, those patients are also getting ID care as well.
And then when they leave the hospital, would they then follow up in your family medicine clinic if they are?
So for their addiction, if they're choosing, if buprenorphine is their treatment of choice and that's where they're headed, then yes, they would follow up with us. We don't have a methadone treatment program, unfortunately. That's something that we've looked into that I would really love for us to get, particularly as we see patients struggling on buprenorphine, but we're also developing or formalizing an MOU with the local methadone clinics so that patients that we see through the consult service can actually essentially have direct access to the methadone clinic upon discharge from the hospital.
And one more follow-up question. Mm-hmm. When patients are in the hospital, how do you identify them as substance use disorder? That's one of the questions we've had here as well, and I'm just curious what your process is.
Right. So sometimes it's obvious. If patients come in for deep tissue abscesses or something like that, or if they come in for an overdose-related event, it's obvious. But otherwise, it's just through basic screening questions that we try to ask all of our patients when they're admitted.
Thank you.
Thank you.
Thanks, Chris. I'm wondering if you could speak a little bit about the dynamics of how to fund comprehensive care integrated in primary care. You have sort of prophy billing, you have grants, you have how does that all work? I know you're not the business person, but maybe you could help us understand if another group is trying to do the same thing, for example, Where is it easy? Where is it difficult? What have you learned? That kind of thing.
Yeah, great question. So I think, and Rebecca, if you could forward the slides, please, to slide 11. Oh, I'm sorry. Restructure it, so keep going. There, oh, you were right there. There we go. What we've tried to do is reevaluate not just how we deliver clinical care, but how our programs are structured, right? And so we've really tried to bring all of the existing programs that we have, the existing special programs that we have within our clinic that serve overlapping patient populations together under the same administrative umbrella, so to speak. So we have the same program managers overseeing the HIV, viral hepatitis, addiction med, homeless, and prevention programs. And so because they're the ones who are managing the budgets, right, they're able to, I think, help us figure out how we can maximize financial flexibility in terms of utilizing funding and cross-training the staff that we have on the ground and integrating those staff into the different programs. So as an example, before, all of our HIV nurse case managers were funded strictly by Ryan White, and we've gradually tried to change that a little bit so that our when we hire new nurses, part of their salary is paid for by Ryan White, but then also part of it is paid for through our Suboxone program and some of these other programs. And they get cross-trained to take care of patients who are in all of these different areas.
So just to follow up, so when you say paid for by your Suboxone program, what does that mean? Do you I'm naive to how that would work.
Right. So primarily, it's actually by seeing patients, right? Because our nurses can, for patients who are stable on buprenorphine, they actually do the follow-up visits for most of those patients, and those clinic visits generate revenue.
Do you have a 340B program through a pharmacy that helps with?
We have a 340B program, but and I don't want to get too deep in the weeds on this because I don't understand it, but our 340B program has essentially been taken over by the state Medicaid program. So Massachusetts has undergone major changes in how they administer their Medicaid program, and so something has happened administratively so that the money that our 340B program was generating is no longer coming directly to us, but it seems to be going to the state now. Again, that is not my area of expertise, unfortunately, so I can't explain why that's happening, but it is a relatively recent change. And that brings up actually another really important challenge that we've faced. So when Massachusetts Medicaid decided to restructure how they do things, they essentially made, they required all Medicaid providers to form what they call accountable care organizations. And the goal of the state was to move from a fee-for-service model to a kind of a capitated model or a global payment model, and then each ACO would get a global payment for each individual patient that was enrolled in the ACO. And so we all did that. One of the unintended consequences, though, was that these ACOs are really tightly geographically based, which for our homeless patients has been really impossible. Which ACO do they enroll in? They don't really have a fixed address, right? So how does that work? What do you do if you... And one of the other issues is that once patients enroll, they're in that ACO for a whole year. So if they move, what do? It's actually really difficult. So that has presented some real challenges for engagement and retention for us. Yeah.
So that's really great. I do want to see all those slides. wondering about methadone. Is there methadone there, and do you work with them for patients that if buprenorphine is not working, as you said?
Yeah, so there are two major methadone providers in the area. One is in Lawrence proper, the other is in a neighboring community called Haverhill. They're both for-profit programs. And as I mentioned, we are working on developing a formal MOU with the methadone clinic in Lawrence. We've always informally referred patients who were struggling on buprenorphine to the methadone clinic, but we didn't have kind of any inside track to ensure that they would actually get there. Hopefully now, as we tighten up this memorandum of understanding, that process will be a little bit more guaranteed in terms of its likelihood of happening.
So I'm wondering about the residents. I think that's great that you have all your HIV clinicians, buprenorphine prescribers. Are the residents, do they get data waived, and are they prescribing, and do they learn that, and is that across the board?
So residents cannot actually get the data waiver until they finish, right? Because you can't get a DEA number until you've finished your residency. So the way it works is that all of our residents do the buprenorphine training, and then they work in collaboration with an ex-waivered faculty member. And so they pair up, so to speak.
Yeah. And, we heard about a program yesterday that said they have very low turnover. It's a well-run program. People are practicing at the top of their license, and there's a lot of job satisfaction. I'm getting the sense that that what you're doing now to address an immediate crisis kind of feels exciting and is fun and is rewarding. Is that the sense you get? And are you having a lot of turnover? And
so I would say that within the HIV, viral hep, homeless, addiction programs, there's a lot of passion and commitment, and we do feel like we're fortunate to have the opportunity to kind of be on the front lines, helping to respond to this crisis that we're seeing in the community. But to be honest, I don't think that is true for all of the clinicians throughout Greater Lawrence Family Health Center.
So let me follow up a little bit on that just for a second.
Yeah.
In the early years of the HIV epidemic, that is, sort of this almost missionary approach. We were all responding to a crisis. There was a calling more than a job. It was really about confronting. Do you see that happening? Are people really like rallying around a greater good, or is that not simply, it's just people doing a job and that's it?
So I think that historically, Greater Lawrence Family Health Center has always been very, very strongly mission-driven. It's what drove the creation of the residency training program, because it was a very, very underserved area. If you want to go to the slide about Lawrence itself, let's see here. Yeah, toward the beginning. There you go. Lawrence is a community that by most demographic indicators is really underserved. It's one of the poorest communities in Massachusetts. It's a predominantly immigrant community with nearly 80% of individuals identifying as Latinx. And before the clinic started in 1980, there was essentially no primary health care. And health outcomes were really pretty poor. And that's in spite of the fact that we're only 30 miles from Boston, 30 miles. And so that's the context. When we interview residents or applicants for our residency program, there's a very common theme of commitment to social justice on their applications. That is a very strong commitment. And I think that is true for the majority of the practicing physicians in our organization. Unfortunately, and I was just talking to Dave earlier this morning, I think it's becoming less true as the organization deals with some of the financial realities of our current healthcare system and serving this particular underinsured population. And so in order to just make ends meet, the focus is becoming more on the bottom line and less on the mission, unfortunately.
As you know, unfortunately, if there's no profit, there's no mission.
Yeah.
But that is true.
Just a couple more quick things.
Sure.
The transitions from hospitalization, as people get hospitalized, they have an addiction issue, your team sees them.
Yep.
I'm presuming that facilitates a transition back into care and prescription and whatever else they need. You have a similar working relationship with the local correctional system?
Yes, actually we do.
Yeah.
So we have a Corrections to Community grant through the Massachusetts DPH, which funds a caseworker whose main job is to ensure that upon release from our local county jail, that those individuals can link back into the system. I will say that it's not been a perfect system. Like the majority of times, our patients or individuals are released without us knowing that they actually were even released. And even when we do know, they often we have no way of contacting them. And, we've actually had, unfortunately, a couple of people overdose in the 48 hours during which we were trying to get them into care. And so that has been really heartbreaking to see, to be honest. I think that there was a recent change in how we're doing things. So now we're actually going in and doing the testing for the jail as well. So not only are we responsible for linkage to care upon release, but we're actually doing the testing as well. So we have more of a constant presence in the facility, which I think is helping, not just in terms of identifying the individuals who are in need of linkage, but also just kind of knowing what's happening and when it's likely to happen.
If I look in my crystal ball, I would suggest that they're going to be starting people on buprenorphine on the inside.
Yes.
And you should probably get on the cutting edge of that.
So we are also we are one of a number of different service providers who are working with the Essex County Jail on their very new MAT program for the inmates.
Great.
So we're also working on MAT linkages.
Great. Yeah. Thank you.
Dr. Cooper.
Hey, good morning. Thank you so much for your work. I actually used to work at the New England Prevention Alliance, which was an early syringe exchange in Lawrence. So,
oh, wow.
Yeah, nice to hear about this. So I you work in a very diverse area, and I wondered if there might be subpopulations defined by gender or race ethnicity that you felt like you weren't reaching through the program as much as you might like, and if you could tell us a little bit about your outreach efforts to those populations.
Yeah, I mean, so I think that one of the take-home lessons that we learned from the HIV outbreak that occurred in Northeast Massachusetts, and we were at the epicenter of that, was that we were not necessarily reaching the homeless population the way we needed to reach them. And so we had separately, the clinic had actually purchased a mobile health unit. And we initially used that as a means of doing outreach to try to go into the major encampments within Lawrence to do testing and identify patients that had already tested positive and get them into care. I will say that Lawrence suffers from an image problem. There was a publication in the Boston Globe magazine a few years ago about Lawrence, and it was entitled "City of the Damned." There is a new documentary about Lawrence called Lawtown, and basically both of these really describe Lawrence in the most negative terms possible. And I think that the leaders of the city are very, very sensitive about that. And they're really trying to fight that. And one of the unintended consequences, I think, of trying to fight that negative image is that policies toward at-risk populations like the homeless are not always the friendliest. And so, as I got off on a tangent, and I apologize for that. But I was talking about how we were using the mobile health unit to go out into the encampments to try to do testing and linkage to care for people who are already infected. Those encampments have all been broken up. So we have no single kind of concentrated encampment for our homeless population anymore. And some of those patients actually have moved out of Lawrence. And those who are still there are often very, very difficult to find. They don't want to be found. So we started by using the mobile health unit for outreach. Now what we're doing with the mobile health unit is providing buprenorphine. So we're doing mobile buprenorphine services on the van. That started in July of last year. We've actually started over 90 people on buprenorphine through the mobile health unit. If you're interested, I can tell you a little bit about some of the logistical challenges about how do you actually get people buprenorphine and do an induction on a mobile health unit. Yeah, that is kind of the key population that we've seen as at risk and that we were not appropriately reaching prior to this outbreak.
One question. Thank you so much. So on the van, do you offer any HIV, hepatitis C prevention or treatment services?
So every single patient that comes onto the van for treatment of their opioid use disorder gets what I call the trifecta of harm reduction services. So everybody gets naloxone for overdose prevention. Everybody gets a referral to our SSP program, which is housed in one of our community-based buildings. There is actually not a clinic there. It's a community-based prevention program, and our van usually parks right next to our SSP program. So we send them inside for clean injection supplies, and then the third thing that we provide for all of our patients, or we offer to all of our patients, is pre-exposure prophylaxis to prevent HIV. We're looking to see if we can start treating hepatitis C on the van. That can be a little bit more challenging. Like, how do you actually appropriately stage their fibrosis before starting them on treatment? How important is that at all if we know that they're recently infected? So we're trying to figure out how to do that well. But hopefully we're gonna start that within the next few months.
Dr. Springer.
Thank you. This is great. And you're doing great work. I had just a couple of questions. So, as you know, retention on buprenorphine or opioid use disorder medication treatments is key for if someone's HIV negative or hepatitis C negative as harm reduction to reduce new infections, but also to help those who are infected, especially with HIV, to maintain viral suppression. So that retention aspect on treatment is key. Can you tell us a little bit about how you're following what you're doing to help retain individuals on buprenorphine treatment in your program?
So I think that the basic answer to that is that we're continuing to see them even if they're struggling. So we don't kick people out of the program in general.
Right. Do you have numbers about how many individuals are how long they're on treatment for?
Yeah. So again, our mobile Bu program is relatively new, and I have numbers for that. I don't have numbers for the program as a whole.
Okay.
Last year, at Greater Lawrence, we prescribed buprenorphine for almost 700 different individuals in the last year. So I don't have numbers for those 700, but I can give you numbers for our mobile Bu program. And actually, So I'm looking at slide 22. It's kind of all the way at the end of the slide deck. Keep going. There you go. All right, there you go. So here are some of our program data. I didn't include the graph that shows retention, but after 3 months, 67% of our patients were still engaged in MAT. The majority of them were still on buprenorphine. A few of them had actually been referred to methadone, but we knew that they were actually getting methadone.
Great.
Yeah.
Those are great numbers. So, I have a question for you. So we've been listening to programs we know about this epidemic, which is also co-occurring with stimulants as here in Northeast Connecticut, where I'm from, and where you are at, cocaine and methamphetamine, et cetera, in other areas of the country that's really impacting. Oh, hello.
Some really young people want to know about
Yeah,
this.
that's awesome. I like how they're starting younger, getting harm reduction. So in addition to that, right, we have all of these complex issues. You're in a state, Massachusetts, a Medicaid expansion state, a high number of buprenorphine providers, like you said, 30 miles from Boston, lots of academic centers, including your center. But yet requiring grant support or other support to maintain some of these programs. In your opinion, what are your thoughts about such a model like we used for addressing the HIV early epidemic using the Ryan White Care Act, where states were given funding specifically to address care? What are your thoughts about such a model for addressing this epidemic?
So similar to what Senator Elizabeth Warren proposed. I think that actually that would be a really important step in terms of ensuring that patients have access to the care that they need. I don't think that it's going to solve all the problems, but I think it's a really important step. I think that we have a lot of other major structural changes in our country that need to happen. First and foremost, I think we need to decriminalize substance use disorder, and until we do that, we're going to be stuck in the same boat. And we also need to utilize interventions, evidence-based interventions that we know are effective in treating people with substance use disorder more broadly. So, but I think that type of a program would really help.
Okay. And what are you doing, as we know, cocaine and other stimulants interfere with the ability for an individual to maintain on medication treatment for opioid use disorder as well as HIV care? What are you doing? How do you guys address continued stimulant use in your patient population?
We're struggling with that, to be honest. We're putting people on Topamax if they're willing to try it. It's been effective for some, but not most of our patients. For patients that seem to have comorbid ADHD, we're trying stimulants to treat them as well. But that gets a little scary, right? It's a little nerve-wracking to give some of these patients stimulants as well for ADHD. We're really struggling. The other thing that we're struggling with when it comes to mixed substance use disorder is that we have a lot of patients who have a primary stimulant use disorder who are overdosing because the drug supply now is almost never exclusively one drug or another. And so we're seeing a lot of people all of a sudden who didn't have an opiate use disorder before, they just had a stimulant use disorder, who are coming in asking for treatment for opioid use disorder because they OD'd unintentionally. So that's a real challenge.
Dr. Chapman.
Hi, this has been great. Can you give us a little more detail about the paradigm shift that you described? What was the philosophy before, and what has it changed to? And secondly, could you give us an idea of the dosing range for buprenorphine and when you decide that it's a failure and you need to move to methadone, and how methadone would work better under those circumstances?
Right. So I was struggling to find the right word to describe our philosophy of care for our addiction program before. I think it was a sobriety model. I think that was the term that I was looking for, was sobriety. And so, we've shifted, and by sobriety, what I mean is that, the goal was to have patients completely substance-free. And when they were not substance-free, if that was a consistent pattern, then they would actually be discharged from the program. We have shifted that paradigm so that we now work on a harm reduction model, and harm reduction is just what it sounds like. We try to take people where they're at. So that means if somebody is not substance-free, but they go from injecting 8 times a day to 3 times a week, that's a huge benefit in terms of harm reduction, huge benefit. And so we absolutely continue to prescribe buprenorphine for those folks. In terms of dosing, we still use 16 milligrams of buprenorphine as kind of the typical dose, but as I mentioned before, with the increased, with fentanyl, particularly with people who are injecting multiple times a day, we're finding that 16 milligrams is not sufficient for a lot of those folks, so we go up to 20 to 24. If they have a hard time maintaining on 24 milligrams, that's when we shift them to methadone.
Are there any prior authorization restrictions in Massachusetts? Is 24 the max dose? And if you could explain that.
Yeah, so there's generally felt to be a ceiling effect with buprenorphine, and so there's not a whole lot of additional benefit to giving them more than 24 milligrams for their opioid use disorder. There is a prior authorization requirement in Massachusetts for anybody who gets more than 16. So anytime we prescribe more than 16, we have to go through the prior auth process. Having said that, our nurses are really, really good, and they almost always get that prior auth same day for patients. So they work really well. Methadone, buprenorphine is a partial agonist, so there is a ceiling effect, whereas methadone is not. So you can continue to increase the dose until you've achieved your maximum response. So that's why methadone works for some patients, but buprenorphine might not.
Chris, is it easier? Are there differences in your ability to provide comprehensive services for your HIV positive compared to your negative patients, or is that not really?
So when you say comprehensive services, do you mean like case management, all that kind of stuff? Yeah, I mean, I think that in theory, at least, it's easier for us to provide those comprehensive care completion services for our patients who are HIV infected because we have Ryan White funding to do that. But having said that, one of the real challenges that we've faced is engaging our HIV infected patients who were not already engaged in care for opioid use disorder into care, particularly if they're homeless. I've been looking into this a lot more recently because over the last 10 months, we've had 7 deaths among our HIV-infected patients with comorbid substance use disorder that were specifically substance use related. There were 5 overdoses and 2 individuals who died of complications of infective endocarditis. And so having done a review of the literature, actually, Jody, your name came up. It looks like you did a meta-analysis back in 2012 that demonstrated that patients who are HIV infected are about 75% more likely to experience an overdose event than those who are HIV uninfected. But you didn't have any answers as to why. I'm still trying to figure that out as well. My theory is that there's this really powerful double stigma that goes along with having HIV and comorbid substance use disorder. And so many of our patients, that particularly those that were infected through this recent outbreak, once they learn that they're HIV infected, they isolate themselves. And that isolation significantly increases their risk for overdose. And that isolation also makes it harder for them to engage in care. Even though, in theory, like I said, we have those case management services available for them, we can't find them. They're hiding.
So I need to just interject a small question then here. You talk about almost 80% of the population in Lawrence being Latinx. Mm-hmm. In your challenges, you talked about difficulty having Spanish providers. What percentage of your providers are bilingual, and how much is that interfering with your ability to provide patient-centered care? What percentage of your patient population is Spanish-speaking only?
Right. So our clinic population reflects the demographics of the city. So the vast majority of them are primarily Spanish-speaking. I would say about 60 to 70% are Spanish-speaking only. All of our residents speak Spanish. They actually go through an intensive language learning program before they start their residency. Most of our attendings do as well, but not 100%. I actually don't have the exact statistics. In the challenges, what I was referencing specifically were behavioral health clinicians. And I think it has been really, really hard to find not just bilingual, but bicultural behavioral health providers who are willing to come to an underserved community, work for not great pay, and see tons of patients a day in order to make their numbers. So that has been very, very difficult. But we do most of our providers speak Spanish, and those who don't, we have access to translation. All of our staff do.
Okay.
100% of our staff.
Sanity? Yeah. Okay. Holly?
Hi. So thanks so much. This is really interesting. I was intrigued in the summary of your discussion with Andrew. There was mention of your discussion on, I assume it's underway, of the possibility of including patients in the interviewing process, and that's related to what you're just talking about now. So would you say some more about that? Say whatever you like about that. I'm just interested how you think you might, implement that, and what your thinking is behind it.
Yeah. So I will be honest and say that that's not an idea that's original to us. We got that idea from Boston Healthcare for the Homeless, who started doing that when they opened up their SPOT program, which is this really innovative place for people who are suffering, who have recently used, and they can kind of go and get care if they need to. I've already mentioned that a lot of our staff are struggling with the harm reduction model, and even we as clinicians often struggle with that. And I think that one of the ideas that we had in terms of how can we help our staff is by having any potential new staff interviewed by somebody who's actually suffering from substance use disorder. Because I think that those people are the ones who are, those individuals are the ones who are most likely to be able to help guide us in terms of selecting the right people for the job, so that this burnout over harm reduction may be less likely to occur.
Dr. Baldwin?
Thanks again for being here. We really appreciate it. If you could rate your organization on the SAMHSA-HRSA integration scale, where do you think you are in terms of integration, and what have been some of the barriers you've experienced, and how have you overcome them?
So can you familiarize me with the scale itself, please?
Yeah, it has 6 different levels. So minimal collaboration, basic collaboration at a distance. Then there's the co-location feature. So basic collaboration on site, close collaboration on site with some system integration. And then the highest levels are close collaboration approaching an integrated practice and full collaboration in a transformed practice.
Yeah, I don't think we're definitely not at that last level yet. I don't think we're even quite at level 5. I think we're probably closer to level 4. And I think the weakest link for us has clearly been behavioral health. That has been the weakest link. Now we just recently got additional funding to hire a behavioral health worker to support our mobile Suboxone program. So we're in the process of trying to find that person, and that might be somebody that we actually utilize consumers as part of the interview process, but we haven't yet hired them. And I think that once we do, hopefully we'll bump up on that scale to the next level.
Dr. Chapman?
Have you thought about telemedicine for behavioral health, actually hiring someone who is culturally competent in Spanish and even if they're not local, but using a remote hookup?
That is definitely something that our clinic has been investigating, specifically related to behavioral health. Having said that, it's not something that is fully implemented at this point in time, but it is something that we're looking into, and I think it's a great idea.
Sure. So I wanted to follow up on Julie's question. So if you wanted to move kind of further up the scale to integration, what policies might be standing in your way?
What policies might be standing in our way?
Yeah.
That's a good question, and I haven't really thought about it a lot in detail. I mean, I think there are clearly like some of the administrative, logistical issues. Like, for example, our clinic cannot get paid if for a patient who sees more than one provider on the same day, we only get paid for one of those visits, right? So that's a potential barrier to complete integration. We essentially, on our HIV team, we do this all the time where the nurse will see the patient the same day that I'm seeing the patient, but we basically take that nursing visit as a loss. But we can do that because we get funding through Ryan White to help support that nurse's salary. For some of our other staff who don't have as much of their salary, supported by grant funding, when they lose a visit, that really matters financially, and so that's a challenge.
Just a follow-up question: Do you have to keep within your electronic health records the mental health records segregated from the other health records? And if so, how does that affect the integration?
They are not necessarily kept separate. Some of them, so they're all there in the same EMR. Whether or not they're visible to the primary care provider depends on whether the patient asks the behavioral health provider to lock the visit. If the visit is locked, then we can't see it.
So I'm going to take a prerogative to not have the 3 other questions because we have exactly 5 minutes.
Okay.
And just give you 5 minutes to conclude and make any concluding remarks that you have, and maybe show a couple slides that you think we ought to see right now, or maybe talk about some of the challenges. I really like that you had some recommendations for other programs, like what advice would you give other programs? So help us a little bit. This is the opportunity to also tell us what we ought to really make sure we put into this committee, into this report as recommendation.
Yeah, so, all right, so can we go back then, Rebecca, to the where we are now slide? because I think that this really captures an important picture of new infections over time. I think I'd have to have a lot of hubris to say that the decline in new infections that we've seen in 2019 is due solely to the interventions that we've made. I'm sure that there are a lot of complex factors that have driven this change over time. But I would like to think that at least some of those interventions have played a role in decreasing new infections. I think one of the key interventions that I did not talk about that has really been helpful is starting a syringe service program. We did not have a syringe service program in Lawrence before we saw those 5 new infections in the summer of 2016, which kind of just blew our minds because that was just so much more than what we were used to. And so we immediately went to the city, appealed to the city's health board, and said, "Hey, we need SSP." So I think one of the things that all of our community health centers should be doing is making sure that if they don't already have a local SSP program, is that they work with the local health boards to institute an SSP program. So I think that is really critical. So that's one recommendation that I would make. And then I think that it really has been helpful for us to have all of these different special programs integrated in terms of their leadership, the programmatic leadership, the people who are doing the budgets, because they can figure out how to support staff members' salaries and get them cross-trained in all of these different areas. So I think that has been another real key to our ability to integrate services, is having the same people in charge of all of these different programs that are serving these overlapping populations. It just they have a broader vision, they have a sense of what's going on in all of these different areas, so they understand what the needs are and kind of where they can move people and move money to meet those needs. And then I think the family medicine model, I'm a huge family medicine champion. Like when you look at the 4 key elements of integrated care for people suffering from opioid use disorder, substance use disorder treatment for HIV and hepatitis, pre-exposure prophylaxis, and behavioral health, family physicians can very easily do 3 out of those 4. And most of the time we're doing all 4 out of those 4. Now that doesn't mean to say that just because an individual provider is able to provide all 4 of those care in all 4 of those different areas, that the care is truly integrated for the patient. I think integrated care involves a lot more than that. But I do think that having a family medicine model really helps in terms of executing integrated care at the patient level.
Well, thank you, Chris. We're out of time, so we really appreciate your presenting, your discussing. I think this is a very rich discussion, and we may be back with you with a couple extra questions, but this was incredibly helpful. And again, congratulations for all you're doing. Thank you very much.
Thank you so much for giving me the opportunity to talk today. I really appreciate it. And I also want to thank all of my fellow team members back in Lawrence. It's a privilege to be able to be here and represent them. But certainly I wouldn't be able to share with you what I'm sharing if it hadn't been for the hard work of everybody back home. So thank you.
I'm sure of that. Thanks a lot. And you're welcome to stick around. You're welcome to whatever you need to do. Thank you.
I want to work for everybody else.
Thank you.